Hi there, I'm Roger Frost, and I'm here today with Dr. Elliott, who is with the University of Virginia Neurological Department down in Charlottesville. He also is involved with something called the ALS Clinic at UVA. And the first question I have of you is, what exactly is a clinic in this context?
That's a great question. The first thing I would say is that it is multidisciplinary, meaning that we have a large team of a lot of different people that each have a different area of expertise. And our whole goal is to take care of and support folks with ALS. That team does consist of doctors like myself, who are neurologists primarily, and we do have at our clinic and many other clinics doctors with pulmonary or respiratory expertise, and who often work with respiratory therapists, and we have a number of other therapists that include physical therapists, occupational therapists, a speech and language pathologist, and we have, as many other clinics have, a social worker. We have ALS Association representatives, MDA representatives. We have often involved a genetic counselor, and oftentimes there are folks that help support mental health, such as a chaplain. We have that in our clinic as well.
Good. Now, can anybody join the clinic, so to speak, as a patient, or do you have to be referred? How does that work?
Given that the goal is to take care of patients with specific conditions, namely ALS or other motor neuron diseases which are less common, such as PLS or primary lateral sclerosis, or PMA, progressive muscular atrophy, or progressive bulbar palsy. Again, different forms of motor neuron disease. ALS would be the most common. Our clinic is geared towards that, and so you really need to have a diagnosis of one of those diagnoses to participate in the clinic, so typically that would be a referral that would be placed by a PCP, a general practitioner, GP, or another neurologist would be referred to one of us. A neurologist may see somebody and confirm the diagnosis outside of the clinic. Once a diagnosis is made, then we can transition a patient into that clinic for the specialized care.
The reason I ask that question is we go to the ALS support group in Northern Virginia, and I've raved about the kind of service we get down here. And quite a few people have asked, well, can you give me some contact information? And I've passed that on. So it'll be interesting to see if anybody has actually joined. Now, tell me about the kind of treatments that are currently available for ALS, if any.
Mm-hmm. Well, we do have treatments. There are two FDA-approved treatments that we use. We have had a medication called Rilitec or Riluzole.
That's what I'm on.
For a long time. And I would say most of our patients are on it, such as yourself. And it's an oral pill. It's typically easy to take. There are a few side effects, but...
What are the side effects?
Well, that's a good question. This is important. Side effects, mainly, one thing we watch out for is liver injury. So we typically check and then follow the liver function test for a period of time. So that's pretty uncommon, but it can happen, certainly. It's something we watch out for in the labs. It can also cause people to feel bad in general. We use the word malaise maybe, but people just feel ill or fatigued.
That's me.
Tired, yeah.
That's me.
So that is a pretty common side effect of the medication, and one that some people can fight through. Sometimes we can use a lower dose to ameliorate that symptom. Sometimes there can be GI side effects as well, but that's the most common.
Okay. And what about the other medication?
Oh, yes. So, and then I guess I would add the other thing about the medication. The goal of the Realitech medication is and the purpose is to slow down progression of ALS, and it certainly does that, and has excellent evidence that it does that.
Oh, good.
The other FDA-approved medication is called Radicava or Edaravone. That medication we don't use as frequently, and there are a number of reasons for that. One is the efficacy data, or how well the drug works. It's not as robust as the Realitech medicine, so that's one reason. So we don't think it works as well for most people. It doesn't mean it doesn't work well for some people, and I think and believe we need to study the compound more, because there really does seem to be a certain subset of patients that it does benefit greatly. But for a lot of people, I don't think it works as well. And then the other reason is it's unfortunately not an easy oral pill to take, and that's a biggie. It's unfortunately infusion. And that infusion may take several hours, and then IV access can be a problem, because it's a medication that has to be administered quite frequently. And so when you're thinking about maybe every day for 2 weeks, every month.
Wow.
And then several hours, and the impact that has on a person's quality of life, and with the relatively modest efficacy, it makes you think about it.
Yeah.
And again, I think it's FDA approved. It definitely works, certainly for a subset of patients, and there are patients that it's totally worth it for, and there are patients that it may not be worth it for. It's a very individual decision. And I think every patient with ALS should talk about it, with their doctor.
Well, the doctor that recommended me to come here was very much against it, actually. Which reminds me, I saw him about 2 or 3 times. Came down here, haven't seen him since. I mean, I've really basically cut myself off from the local neurologist. Is there any reason for me to go back to him, do you think?
That's a great question. I think it's an individual question. I think if you have a diagnosis of ALS and you don't have other neurological issues, and
I'm totally insane.
Well, aside from that, and you have good access to an ALS clinic and an ALS doctor, and are fortunate enough to have that. Ready access, then that may be the only neurologist that you need. I do think even in that case, it would be important to still have a primary doctor, a GP.
Oh, we've got that.
Because certainly other medical issues come up that a neurologist such as myself may not have expertise, and we. I would always work with a general practitioner or any other doctors, such as a pulmonologist that I mentioned before, or any other specialists that need to be part of the care in taking care of an ALS patient, because it's a complicated disease with a lot of different issues. If someone didn't live very close to an ALS clinic or a neurologist with ALS, a primary ALS experience, a multidisciplinary clinic like this, then oftentimes we will partner with a local neurologist. So that there can be local care with a doctor a neurologist that's aware of ALS, and then we can partner with them to provide local care, and then they can come see us when they're able.
That's a great idea.
Yeah. And then the other thing that I would say that we used to extend, hopefully if you forgive me, that we used in our clinic, and a lot of other clinics it's becoming more and more common, is telemedicine. And so we're trying to break down that access barrier and provide the expertise of our clinic to folks that may live pretty far away, and it may be difficult to get to clinic. So we're working on those barriers, but sometimes we can't, and they need a local neurologist too.
I understand. And the final area I'd like to ask you about is, as a neurologist and ALS clinic or clinician,
Sure.
is there anything on the horizon that could give patients like me any hope in terms of research or the trials of drugs or treatments?
Yeah, well, I think that's an excellent question. So we discussed the FDA-approved treatments, and I think it is important that a patient or a person discusses all of what we know works or what may work. We have good evidence for what works with our patients, but beyond that, what we have is things that can slow down the disease, and we need to get better, and we need to get smarter. And that comes through research. And so I encourage all my patients that are interested and capable to participate in research. You're one of mine. I appreciate that so much. It's so important. So there are ongoing, in the pipeline, and we talk about drugs being in the pipeline that we're still testing, that are not ready for FDA approval, but we are excited about and think may work to help for ALS. There's about 60 drugs right now in the research pipeline. It's it's an incredible amount of things that we're excited about that we need to study, and so we need participation of folks like you to help us test these drugs. Which ones work? Which ones don't work? If they don't work, we'll move on to the next one. So there's a number of things that are exciting right now. A drug that we're testing right now is called arimoclomol.
Why can't it just be called Bill's drug or something like that? I mean, because I can't pronounce this.
I know. I don't know. Maybe someday. Well, so at least in the testing phase, they use these sort of generic names, and then when they get FDA approved, they will probably come up with some brand name that'll be easier to say. So if it works, you'll probably have an easier one to say in the future. But yeah, I feel like sometimes they make them complicated on purpose. I don't know, but that is a really interesting drug that enhances heat shock proteins, and we feel that may be we know that it's neuroprotective, and we're hopeful that it helps slow down ALS. So that's one we're really excited about. Going forward, other trials that are really excited about that we're not involved here at UVA include stem cell therapy. That's extremely exciting. Some of the most exciting research I think ongoing right now is some of our potential genetic therapies, and so they're about 10% of ALS. We can identify a genetic cause through genetic testing, and the two most common genetic forms of ALS are SOD1 or SOD1 and C9orf. And currently in research, we're studying therapies targeted to those specific genes. And I think if we can target those genes as a genetic cause for those people, which again would be, in total, they would be less than 10% of folks with ALS, we have the chance to potentially halt the disease.
Wow.
So it's extremely powerful, and we're very, very excited about those. The only downside is it's 10% or less of people.
Yeah.
So we need to use that to find further treatments. For everybody. 100%. Certainly, that's our goal. And I will just say one more thing that I'm extremely excited about that we are gearing up for here at UVA, and is a totally new kind of trial. It's called the platform trial. So I mentioned that there are 60 drugs that potentially that in the pipeline that we need to study. So traditionally, when you do a drug trial, you study one drug at a time. Half the people are on the drug, half the people aren't on the drug, and you compare the two groups over time.
Yeah.
See if somebody does better, somebody does worse. But with 60 drugs,
it's going to take years.
It's going to take years
Decades.
and years, decades. Yeah. So we need to find a way to do this faster, more efficiently. Find the drugs that work faster. Test the drugs that don't work, and move on to another potential faster. And so with this new platform trial, which is being centered at MGH in Boston, but there's going to be sites, 50, maybe even 60 sites all over the U.S. and Canada at least. So huge trial. We're going to be studying not just one drug at a time, but multiple drugs at once. 3 to start, potentially up to 5 or in the future. And so that allows us to study drugs faster, more efficiently, get them hopefully to FDA approval and to our patients faster. And then the other benefit with this particular trial, instead of half of the folks being on drug and half not, we can use what we call a shared placebo, so that we split the folks into quarter not on drug, and then 2-3 other quarters on drug. So it's a 3-to-1 drug to placebo ratio. So if a person were to enroll in this trial, they would have a greater chance than a lot of the other trials out there to be on something that might work.
Wow.
So,
well, thanks so much for all this information, and I hope you enjoy watching yourself on YouTube.
Thank you so much, Roger.
Thank you. Take care.